as you know, most of our body is covered by a layer of cells called the epithelium, and that's a lining that protects us from infection and injury, etc. And that is the same on the surface of the eye. So the conjunctiva and the cornea, they all have an epithelium. Skin does. And it's attached to the layers below, so the substantia propria, as you've heard, and or the stroma, as it's known, like with a Velcro type, what we call a basement membrane complex. So you've got the layer of cells, and they're attached to the rest of your body with almost like a Velcro-like system. And that's precisely where you get the immune response in pemphigoid. So it attacks that junction between the two, and that's where you get, and then you get the scarring underneath that in the substantia propria. So essentially, what happens? This is a picture of you've just seen in John's talk as well.
I meant to say, Sergeant, the pemphigus diseases, the targets are the attachments between the epithelial cells. So that is much more superficial, and that causes awful blistering, but not scarring.
Yeah.
Such. It's not actually an issue for eye disease generally. So the pemphigus diseases are all in the epithelium.
Over here.
Eye diseases are down
here.
You know, just a little bit, just a few microns deeper. It's nothing. Really.
And very different diseases, in the way they behave. So, so this is what goes on. Don't worry about it. It's very complex, even for me. So, and the top bit's a different disease altogether. But this is essentially what goes on in pemphigoid. So a lot of responses going on with your immune system and that structure that we've just described. But essentially what happens is you've got two different types of cells in your immune system, B cells and T cells, and both of them are active at different stages and sometimes together, often together, in pemphigoid. So when you get your acute response, so the initial injury where you get the immune system responding to that Velcro, the basement membrane complex, you get the production of what we call antibodies, and these target the basement membrane, as John's explained before. And then on top of that, you get the T cells coming in, you get this chronic inflammation, so you get this underlying chronic disease, and you get episodes where it flares up. And all of it ends up with scarring. So you've got two responses in pemphigoid. You've got the inflammation, which causes a pain, and sometimes if it affects your cornea, it can affect your vision and causes ulceration. And then you've got the other component to it, which is a scarring, which causes the long-term problems, the lashes turning in and the lids turning in as well, which again causes problems to the cornea. So the idea here is to prevent you from losing vision and improving your pain. So the inflammation and the scarring. Now, there are two aspects to pemphigoid, and they're both very important to understand. As you will probably in this room, everyone who has pemphigoid will have a range of disease. So we see some patients who have mild disease and always stay with mild disease, and a small subgroup of patients, luckily a small subgroup of patients who are at the top of this pyramid, and they get very, very severe disease that is very difficult for us to control, okay? So the severity of the disease in pemphigoid varies from one person to the other. And the other aspect is, this is taken from, oh, it's not come up. This is taken from multiple sclerosis, which is another disease which has an immune basis. But essentially, pemphigoid behaves very similar to this. You'll have some patients who have disease which stays the same, and they might get little flare-ups, so like the top one, but they never really get really bad where you get they won't get lots of scarring, they may not get corneal disease. But other patients have episodes where it flares up, they get worse, so it's a second graph here. And then other patients just continue to get worse throughout, whatever you do. And pemphigoid is very similar to this. I have much less experience than John does. John got me interested in pemphigoid in the first place. And the more experience you get, the more you realize that everyone's disease behaves very differently. So you have to tailor treatment to each person differently, depending upon how they respond to the disease, depending upon the side effects of the different drugs you use. Because some of the drugs we use are they suppress your immune system, so they can be quite toxic, which is why we monitor it very closely. And we use this this step-ladder approach to treatment. So we look at the way the disease is behaving. Sometimes very early on we have to use quite strong drugs, so cyclophosphamide, as you've heard, or immunoglobulins, for example. But in most patients, we try and assess the disease early on, and if they're not too inflamed, we start them on something called dapsone. Some of you will be on that. And then we try not to use steroids, as John said, for long periods, but we often have to use it early on if the disease is severe. And then we go on to longer-term safer agents, or what we call steroid sparing agents called mycophenolate. And then if the disease is really bad, then we go on to cyclophosphamide and rituximab. And I'm going to talk a little bit about rituximab for the remainder of the talk. So rituximab is essentially it targets something called CD20. I'm not going to go into too much detail about the immune basis, but I will describe parts of it because it's important for us to understand how it's working. And it's basically CD20 is expressed on the B cells. So I mentioned the B cells earlier, which produce the antibody. And the rituximab is an antibody that targets that. So it blocks the CD20 on the B cells, and therefore it leads to its destruction through that mechanism. So you're basically destroying the B cells that produce the antibodies that target that Velcro, the basement membrane complex. Interestingly, whilst I was researching for this talk, the US patent that we've just discussed was issued in 1988, but it actually expires this year, and I'm not sure exactly what they're planning, what the plans are.
Trying to get an extension.
Are they? That's only in the States, though, so I don't know what happens in Europe. But that may help us with funding potentially. I just found that out, so we'll see what happens. And interestingly, rituximab wasn't used for scarring disorders. It was originally developed for the treatment of immune system tumors, so lymphomas. Okay, and that's where most of the experience comes from using rituximab clinically when we give it to patients. The important thing to say is that, like most of those drugs, it does have side effects. It's not that rituximab we think works and so should be used in everyone. It does cause quite severe reactions sometimes. So when you get the rituximab through your bloodstream, it can cause what we call an infusion reaction. So you can become allergic to that, to the drug. We know that some patients get lung problems afterwards, and certainly I'll give you my experience that I have with the patients that we've treated, but probably about 50% of them get a very dry cough afterwards, funnily enough. And so there must be a grade of pulmonary disease or lung disease that they get. So some patients must have quite a severe response where they get really bad lung disease and it causes chronic problems or long-term problems, and other patients just get this irritable cough that eventually settles down. The other thing that someone asked me about 2 days ago from Edinburgh was whether or not one of their patients could go on rituximab or should go on rituximab for pemphigoid. And interestingly, they also had bowel problems. And I have had one patient in my group who ended up having problems with their bowels and they developed ulcers. So rituximab in a small subgroup of patients can cause problems with your bowel. So usually if you've got bowel problems or stomach problems, then we try and avoid it. And then the other thing to note is that we know in the group of patients that have been treated with rituximab for all sorts of diseases that it can flare up certain types of hepatitis, so viruses within your body that lie in a state of what we call dormancy, where they're asleep. Suddenly, by giving the rituximab, it can flare that up. So you can get liver disease, and very, very rarely there's a virus called JC virus, which is named after someone, and that can cause a brain inflammation. So rituximab works well in the group of patients that have been treated in some of them very well, but it does have side effects that we need to be aware of, and that's part of the reason for having that stepladder approach. So who do we end up treating at the moment with rituximab if we can get the funding for it, which, as you've heard, is a bit of a complex issue. So if someone, patients that I've put on the treatment and trials that have been done in the States, on those trials, if you've gone blind in one eye from the pemphigoid, so basically if you've had the disease and it's caused problems already, then we can potentially get funding for rituximab or get access to it. If you've got inflammation that continues to get worse, despite all the other treatments that you have on that stepladder, then we can use rituximab. If you're going to go blind because your corneas are starting to get scarred, as you saw in John's pictures there, and blood vessels are growing over, then we can use rituximab. So there are some subgroups of patients where we really need to use rituximab. You have to have it further down your step ladder in an ideal world than the other medications. And interestingly, I've had 2 patients who can't take their regular medication for various reasons because they have other problems as well. So the beauty with rituximab is you can give it as you come into hospital, you get it as a drip, in your arm, as an infusion or a drip, and 2 weeks later you get the second dose, and that's you done for about 3 to 4 months on the whole. Okay, and then there's we do monitoring after 1 month, but we don't need to do it for the rest of the time. So essentially, it helps with patients who we can't monitor, can't get to us, and so in those group of patients, it's actually helped considerably because otherwise they would have had active disease and gone blind very early on. So the other issue that we have with rituximab is that the treatment protocols, so the way we treat patients and the doses we use of rituximab come from experience from other diseases. So lymphomas, as you've heard, from the immune system tumors, the rheumatoid arthritis, that's where our experience comes from because that's where it's been used the most. So the 2 different protocols there is this dose called 375 milligrams per surface area, and you give that every week for 4 to 8 weeks, or the other option is you give a gram of rituximab on day 0, and then on day 14 you give another dose, and that's it. That's that done. So those are the 2 different doses. Now the 375 one comes from lymphoma, and the 1 gram comes from rheumatoid treatment. So they're both protocols that have been used much more than in pemphigoid, and so that's where most of our experience comes from on the safety of the drug and how well it works in autoimmune diseases. And basically, when you come in first, you come in for a longer period of time to get the drug because we do it at a slower rate in case you develop a reaction to it. And you're monitored by the nurses, so they do your blood pressure and monitor you at regular intervals during that period. And so you're in for most of the day, and you get a slow infusion of the drug. And then if you need repeated doses, so after about 4 months, then we can give it much more quickly, so you're only in for a few hours. And what happens is that because it's affecting your B cells, we know that in other systems and also in pemphigoid that your B cells fall by about 1 to 3 weeks. So you can't find you don't find them in significant density within your blood. So and we monitor it. Interestingly, it targets CD20, but we actually monitor it by using CD19, which is another marker on the B cells as well. And we do that at 1 month just to show that the B cells have gone down, and it does in most of the patients. And it says on the safety issue from the company that you shouldn't use a drug before 16 weeks. So that's 4 months. So often what happens, and I'll explain to you from my own experience with pemphigoid, usually around that time it seems to start to flare up again slowly. And so at 4 months you often have to repeat it, certainly in the small group of patients I've dealt with. Or depending upon how bad their disease is. So some patients by 4 months they'll be fine still, but later on they're starting to flare up, so you use it at that stage. Now you might say, well, why are we treating the disease when it becomes active? Why aren't we treating it before it becomes active? Well, we don't have enough evidence that works, so hence the trial that we'd quite like to put through in the next hopefully in the next year or 2, and ideally get funded, because we think that probably will work. So, do we use rituximab when the disease is active, or do we use it before it becomes active as a prevention of the disease from worsening? So my own experience is in 6 patients that have pemphigoid, mainly in their eyes, but also other parts. So they have throat disease. A few of the patients have throat disease as well. 4 men and 2 women. All were ineffective to routine treatments on that step ladder, and so because their disease was still active, we had to resort to another treatment modality. I was quite lucky in Liverpool. We have access to rituximab slightly more easily, and that's partly because we have someone who uses it for kidney disease where they get autoimmune problems as well. So we've basically tagged on to the end of their their procedures and had access to it. We've had 3 of those patients that were treated were already blind in one eye before they came to us. So, and because they'd already had treatment and they couldn't be controlled in the other eye, we went straight to rituximab. We also used IVIG on 2 of the patients, but I won't talk too much about that because that's slightly controversial as to when we use it and when we don't. 2 patients had very aggressive disease with corneal involvement already, so we again we had no option but to use rituximab. And 1 patient, as I say, I've had another one recently, we were unable to follow them up because they come from both of them actually come from the Lake District, so they're from far away and don't have access to treatment very easily, so they have to come down. And so and they had, with conventional treatment on the stepladder, they were getting reactions to almost everything that we were giving. So we gave them rituximab and they've been fine, or this patient's been fine anyway. The other one we've given it to recently. So most of the patients that have had the treatment with rituximab have cut between 4 and 43 months following them up. Usually you notice a significant reduction in the inflammation by about 1 to 2 weeks. So if it's going to work, and it has done in all of these patients, but I'm told that it doesn't in all, from those that have more experience with using rituximab. So most of the patients, you'll notice a big difference in a week or 2. As I say, a cough is common in half of the patients, and one patient had bowel problems. But I do seem to find that about 3 to 4 months, the inflammation starts to come back, so you need to then give another infusion at 4 months. So just to summarise, the treatment of pemphigoid, we know needs to be personalised because everyone has slightly different aspects to their disease, and so this is one of the problems with putting everything into a trial, is that everyone will have slightly different disease, and so you can't compare one person to the other because the disease will behave very differently. So we need to personalise the studies, and personalised medicine is actually quite an important and important thing for a lot of the research councils now. So hopefully, it'll be a good idea for us to get funding on the basis of that. Rituximab seems to be effective, so we haven't done the trials, but it seems to be effective in resistant cases of pemphigoid. The problem is it's expensive at the moment and often very difficult, sometimes impossible, as you've heard, to obtain, regardless of whatever you do. But there are significant side effects. So even if it does work, we have to be aware that they have side effects. So not everyone should have rituximab. And then, as I say, we're hoping to set up a clinical trial within the next year or 2, hopefully, for the patients that we have in the whole country. So we'll hopefully have access on the basis of a research study for rituximab for our patients. So hopefully I haven't made it too complicated, but thank you for listening.